Um, my journey in behavioral health started when I was a medical student. Where initially I was actually, uh, interestingly and coincidentally, primarily interested in cardiovascular disease. I had intended when I first entered medical school, I was considering a career as a cardiologist, and it was only a few years later that I started to appreciate that behavioral health, mental health was a, a fascinating area, an area that was really, in the 90s, there was a lot of stigma attached to mental health, a little bit of prejudice against mental health. But you could see that in terms of our knowledge base, there was a lot to learn. And in fact, my perception was that we had a lot more to learn in relation to behavioral health conditions, and decided to take a risk and consider a career as a psychiatrist as opposed to a career in cardiologist. Always thought that there was a distinct possibility that I could return to cardiology if I really wanted to. But I can't say I've ever looked back. I'm fortunate to be in the position that I am. Grateful, and also grateful to be able to share a psychiatrist's perspective on cardiac conditions, cardiovascular conditions, including the aortic disorders. Before I begin with my presentation, I do want to acknowledge some disclosures that I have. I have research support, and I've been very fortunate to obtain research support through the National Institutes of Mental Health here in the US. By the way, I'm on the West Coast, so it's middle of the afternoon for us. It's a beautiful day here in San Diego. I was just in Toronto, and was fortunate enough to be able to partake in the wonderful weather of the weekend. But I know a lot of you are spread throughout the country, so I hope wherever you are, the weather is as nice as it is in California. I was also funded by the Canadian Institutes of Health Research. My career was supported most recently by the Wellcome Foundation, which is an international society that supports healthcare research. Of course, the Temerty family, and most recently, when I moved here to the UCSD, the Kreuzkamp Family Foundation. I have received industry support through BrainsWay for an industry-sponsored clinical trial involving brain stimulation that we were part of, and through MagVenture, we have led NIH-sponsored trials and required MagVenture's equipment to run those trials, including several large-scale clinical trials that I'll talk a little bit about today. And finally, I serve on the scientific advisory board for BrainsWay, although we haven't had a meeting in a couple of years, so I'm not sure if there's a perceived conflict of interest, but I do it at considerable arm's length. Okay, so the history of anxiety and depression in the context of genetic aortic disorders, including Marfan syndrome, is long-standing. And as I mentioned, when I was a medical student and a resident, psychiatry was behavioral health was an afterthought, meaning that it was always, and rightfully so in some cases, the perception that the person's physical condition obviously takes precedent over their psychiatric presentation, and to some extent, the behavioral health consequences of the cardiovascular condition were seen as being understandable. That is, that a person was struggling with a cardiovascular condition, severe cardiovascular condition, so it was natural for them to experience anxiety. It was natural for them to experience depression, and people didn't often inquire until the questions were asked. And as I mentioned, I have benefited in my career to see a huge amount of destigmatization that has taken place with mental health. All extremely positive, because people are now coming to terms with the fact that taking care of one's mental health symptoms can sometimes be as important, if not more important, than their physical health. Ultimately, it's our behavioral health that governs how we lead our lives and experience both positive and negative aspects to our lives. And so being able to be, or being mindful of someone's behavioral health in the context of a severe medical condition is of paramount importance. This paper was published in 2017, and it's a paper that I like to highlight because it's one of the few papers that's been published on behavioral health manifestations of Marfan's patients, and B, it reveals something that I think is of utmost importance, and that is that, as is highlighted in the second point, the author suggests that the symptoms of an aortic disorder can be experienced as traumatic, and can be as severe as a traumatic event, in that it's constant, it's perceived as life-threatening, and it's not something that people necessarily need to endure. In other words, help should be offered. The other key point to this is that there was no difference in relation to depression. So depression was not necessarily seen as an outcome, but certainly anxiety was. And that's natural, because typically when people experience acute distress as a result of cardiovascular symptoms, it's the anxiety that is reported first and foremost, and then over time, depending on the outcomes, there could be cases where depression sets in. Fortunately, in this example, that was not the case. The depression did not differ between the two groups, but anxiety was the differentiating factor between the two groups. So what are the psychiatrics of heart disease? And they can be manifold. One is anxiety, where arrhythmias or arrhythmias from frequent acute coronary events can trigger anxiety. Most of the people on this call are familiar with that experience. I have personally had not necessarily a life-threatening arrhythmias, but we all get anxious, and as we get older, we can experience premature ventricular contraction from time to time, and that can evoke some anxiety feelings. And so it's never comfortable to feel like something is wrong, and so anxiety is an important symptom that our patients with heart disease experience. There's a yin and yang to this, and the yang is that anxiety adversely affects outcomes in coronary artery disease. So the anxiety itself can provoke a considerable adrenergic response, and that adrenergic response adds a lot of load to a person's cardiovascular system, and that can have a negative influence on coronary artery disease. So it's important to consider anxiety not only as a corollary to heart disease, but without getting into too much detail, treating the anxiety, or at least being aware of the anxiety, may adversely affect the outcome in coronary artery disease specifically. Anxiety after MI is common. It's frequent in the context of unstable angina, and anxiety is another manifestation of severe coronary artery disease. And post-MI anxiety, and this is something I want to emphasize, is one of the strongest predictors if in-hospital complications exist. And that relates to something I mentioned, or at least in part relates to something I mentioned earlier, and that is that anxiety drives up noradrenaline, adrenaline levels go up with anxiety, and once adrenaline levels go up, it can actually contribute to complications post-MI. And so managing the anxiety, again, is of considerable importance. And more often, I personally have been consulted many times in a hospital setting when a person was experiencing transplant, when they were experiencing post-transplant, also when they were experiencing coronary artery disease. They'd come in with considerable anxiety, and those patients needed management, because it was hard for the cardiovascular team to get their arms around the condition if their anxiety wasn't effectively managed. Anxiety is when medicated, can have some unintended consequences. It can contribute to heart rate variability, QT interval prolongation. I'm not sure if you're familiar with that, but on the EKG, there's an interval called the QT interval, which when carefully considered, can be prolonged. And some of our medications that we prescribe can prolong the QT interval, and that gets into all kinds of arrhythmia consequences that we want to try to avoid. And so not only is managing anxiety important, but managing the unintended consequences of the treatments for anxiety, particularly medication treatments for anxiety, is something that we need to be very mindful of. And of course, coronary artery disease is associated with high rates of anxiety. I'm having trouble managing the chat. I'm not sure if anything comes up in the chat. Linda, if you could let me know if anything comes up in the chat,
I will let you know.
Great, thank you. I can pause for questions, but if anyone has any questions, feel free to interrupt me. It's just the way the screen is coordinated, and I'm not seeing the chat.
If any questions come up, if anybody has any questions and they wanted to type them into the Zoom chat function, I will be able to see them and can read them to you. And we invite, as you said, any of our participants to ask questions at any point.
Terrific. Depression is also very common in patients with coronary artery disease, slightly higher than the general population. So depression is common in the general population. In any given year, 6 to 10% of patients, 6 to 10% of people will experience depression. It's about twice as high in folks with coronary artery disease. So coronary artery disease can be a significant contributor to depression. Depression is very common after coronary bypass. Depression is common in congestive heart failure. It tends to be an independent risk factor for the development of coronary artery disease. Depression and anxiety are often comorbid, and depression in and of itself can produce a lot of cardiovascular load through its effects on stress hormones. So stress hormones go up when people are depressed, and those stress hormones can actually contribute to the development of coronary artery disease. It's kind of like that, the old analogy of the type A personality. That is the person who's under a considerable amount of duress, who, because of that duress, which is longstanding, could experience coronary artery disease. Depression itself quadrupled the relative risk of cardiac mortality in those with coronary artery disease. That is, and these last 2 points are of considerable importance. That depression, when left untreated in folks with cardiovascular disease, can be a predictor of morbidity and mortality. So being aware, being cognizant, and addressing people's behavioral health concerns, particularly as it relates to anxiety and depression, but for that matter, any behavioral health concerns that people are experiencing, they need to be addressed. And because if they are effectively addressed, you can significantly improve patient outcome.
May I ask a question at this point that we had submitted prior to?
Of course.
Are antidepressants safe to take when you have a genetic aortic disorder or you've had an aneurysm or a dissection?
The short answer is absolutely. Antidepressant medications are extremely safe, especially the SRIs and SNRIs, which have been available on the market for many, many years. There are isolated reports of arrhythmias, as I mentioned here in this slide, potential vasoconstriction, which is a real remote risk. The major risk with SRIs that people are now, certainly in the last 4 or 5 years, become more and more aware of is the risk of bleeding. And so SRIs do affect platelet function, and it's a sensitivity that we all very much pay attention to, because affecting platelet function in a person who has a potential diathesis towards bleeding, for example, if you've had a stent put in, or if you have a valve replaced, or if you had a graft and you need to be on blood thinners, SRIs can contribute to bleeding risk associated with blood thinners. And so we tend to stay away from SRIs in those conditions. Venlafaxine is an SNRI. It tends to elevate blood pressure because of its noradrenergic response. And TCAs are older. We don't use them much anymore, very sparingly, but they have been, and part of the motivation is shifting from TCAs to SRIs. TCAs are tricyclic antidepressants. They're an old generation of antidepressant. They even predate me in my career. That is that TCAs were used extensively in the 70s and early 80s, but because of their risks, including orthostatic hypotension, conduction deficits, sinus tachycardia, supraventricular tachycardia, VFib, VTAC, these are all cardiovascular side effects that TCAs are associated with. TCAs are also very anticholinergic, so they can raise heart rates that way, which leads to sinus tachycardia. They can cause dry mouth, constipation, etc. And so they have significantly fallen out of favor, even though they were quite effective in treating depression at one point in time. Be that as it may, they're not used commonly, but they are also associated with significant cardiovascular events. Now, I will tell you that some TCAs at low dose can be used effectively, and we often see medications like amitriptyline be used in the treatment of certain pain conditions. And so at low dose, they can be used effectively in certain types of conditions associated with cardiovascular disease, but they also need to be carefully monitored, not just with regards to arrhythmia, but also in relation to some of the bleeding issues that I mentioned earlier.
Okay, thank you.
Cardiovascular effects. Now, neuroleptics are a group of medications that we don't typically use in depression, anxiety. Occasionally we do, but they're mostly used in the context of illnesses like schizophrenia and bipolar disorder. These have classically been associated with what's called prolonged QT and hypotension. Hypotension is a drop in blood pressure and is very common with clozapine. The other medications aren't even worth mentioning because they're not used that commonly. But clozapine we do see, and clozapine can cause what we call orthostatic hypotension, or hypotension associated with getting up too quickly. Deprasidone, quetiapine is often used in the context of managing anxiety. And so we do in sleep disorders. Quetiapine can be very effective in managing sleep. Risperidone is a medication that we use in schizophrenia. Haloperidol medication we use in schizophrenia. And olanzapine, also a medication that we use in schizophrenia. Those are all medications that are associated with prolonged QT. And again, the QT is the QT interval. It's that interval, cardiovascular interval, that can be important, that is important to monitor in the context of medication use, because it can become prolonged. Certain medical conditions can also prolong it, but it can become prolonged. And if the QT interval is prolonged, then it puts people at risk for life-threatening arrhythmias. So something to be mindful of when you're receiving care. There's a considerable overlap between medical and psychiatric conditions. I mean, I have spent the last 15 or so minutes talking about that, but important to keep in mind and to keep it balanced. So psychiatric presentations can present with medical conditions. Medical presentations can present with psychiatric symptoms. Psychiatric psychiatry or behavioral health conditions can often complicate medical conditions. Medical conditions can often lead to severity or worsening severity of psychiatric conditions. And then there's psychological reactions to medical conditions, and then there's comorbid medical conditions that are affiliated or associated with psychiatric conditions. And I'll give you examples of each of these. But what this slide highlights is that it's almost like you can't have one without the other. That's what these diagrams show, is that there's considerable overlap between having a medical condition and having a psychiatric condition. And while we're thinking about our medical conditions, we often have to be very mindful of our psychiatric condition. Again, when I entered psychiatry, it was not something that was routinely done. But I can tell you now, in most general medical settings, including procedural settings, they screen for anxiety, they screen for depression, they screen for suicidality because of the high incidence and prevalence of these conditions. Something important to be mindful of. Psychiatric presentations in the context of medical conditions. I gave you an example of one, coronary artery disease, which can be associated with depression. Medical presentations in the context of psychiatric symptoms. There's a number of medical conditions. You can have an arrhythmia if you have a severe anxiety, and that arrhythmia may not manifest as anxiety, or sorry, the anxiety may not present as an arrhythmia, may not present as anxiety, but it presents as arrhythmia. And then you realize that when you scratch the surface, that this person is trying to manage their anxiety in various unintended ways. Psychiatric complications because of medical conditions or their treatments. There are a number of medical conditions that can worsen psychiatric. So, for example, if you are using a particular medication, like a steroid, steroid use is pretty ubiquitous. You can have psychiatric complications in terms of steroid use with both depression and mania taking place, as well as anxiety. Medical complications of psychiatric conditions. We've seen that coronary artery disease, as I mentioned, anxiety disorders, depression, schizophrenia, those are all conditions where medical complications are often present in the context of the psychiatric condition. Perhaps a little bit later, but something that we always pay attention to.
May I ask a question, if that's
Of
okay?
course. Yeah,
that I think relates here. A question that was submitted prior to the webinar. How do I manage my PTSD associated with 2 previous dissections and my subsequent depression when I don't have a clinical counselor or a starting point? Where do I go? What should I do?
That's a great question. First, in this day and age, there should be no reason why people can't reach out and find help. I know that behavioral health specialists are not often widely available, depending on where you live, your community, the resources available in your community. If you live in Canada versus the US, and financial conditions, oftentimes you need insurance or you need to pay out of pocket in the US. In Canada, that's not the case. Sometimes you can pay out of pocket in Canada because a psychologist, for example, won't be covered by the health insurance plan. But sometimes, the wait lists are prohibitively long. And so another barrier to get access to treatment. I think it's important, and I'll touch on each of these. The last 4 or 5 slides gets into how to manage one's psychiatric symptoms, behavioral health symptoms. From a holistic perspective, it's not just about medications. It's not just about psychotherapy. It's about engaging with our communities and getting access to the right resources. The internet is a huge resource online right now. And so fortunately, there's lots of companies that deliver online psychotherapy. I know those can be expensive and they can be associated with significant costs, but it is a resource that is available to people, particularly if they're in crisis. Okay, I'll move on to the next slide. Now, I walk through each of these in detail. As I mentioned, corticosteroids are associated with euphoria. They can be associated with mania, psychosis, and misinterpretation of reality. And corticosteroids can present with psychosis and depression. Prazosin is a medication that is typically used for 2 reasons. One is it's used to lower blood pressure. Ironically, prazosin can also be used to treat PTSD and anxiety, but sometimes it has unintended side effects, including the onset of depression that we have to be careful of. ACE inhibitors. ACE inhibitors are blood pressure inhibitors that have occasionally been associated. ACE stands for angiotensin converting enzyme, and they inhibit the angiotensin converting enzyme, but they can be associated with depression, somnolence, insomnia, nervousness. And somnolence, insomnia seems somewhat counterintuitive, because how can you be both insomniac and be somnolent at the same time? And I think what I'm trying to highlight in this slide is, in some cases, people can experience sedation. In some cases, people can experience insomnia. Sometimes the side effects are very personalized. Cyclosporin, which is an old, fortunately, a medication that we don't use it much for as an antibiotic, but it can be associated with some confusion. But beta blockers, which are often used, can be associated with depression, vivid dreams, nightmares, and insomnia. So medical side effects associated with psychiatric medications, SRIs. I mentioned some of them. Hyponatremia is lowering sodium. SAADH is associated with the diuretic syndrome, where you're having to urinate frequently. Seizures in rare events, very rare events. Serotonergic syndrome is a kind of a cardiovascular condition where you can become agitated, confused. It's rare, but it can happen, particularly when you're combining different psychiatric medications. Haloperidol, as I mentioned, QT interval prolongation, it can cause a condition that looks like Parkinsonism, but is not a Parkinsonian, direct Parkinsonian outcome. But that rigidity, stiffness, gait imbalance can be associated with haloperidol use. Haloperidol, of course, used in conditions like schizophrenia and bipolar disorders. Aprasidone, also a medication that's used in bipolar and schizophrenia. Quetiapine, often used in anxiety, can be associated with cataracts, with syncope, and with hypotension. Clozapine, a medication that is almost exclusively reserved for patients with severe schizophrenia, can cause an agranulocytosis, which is a drop of the white blood cell count, and also cardiovascular conditions, including myocarditis. And the prevailing thought is that clozapine increases heart rate, and over time, that heart rate can lead to a myocarditis. That heart rate increase, rather, can lead to a myocarditis. And in rare cases, antipsychotics and some other psychotropics can lead to what's called neuroleptic malignant syndrome, which is a high fever and rigidity we often try to avoid. Depression is something that we need to also be very mindful of, because it affects either directly or indirectly, it affects nearly everyone on this planet. Directly, of course, 6 to 10% of the population every year can be affected with depression. It affects, I think it's about, the statistics are about 1 in every 15 or so people. It can lead to, and that translates into millions of people across the globe being affected. It can lead to functional impairment that is equal to or surpasses that of many chronic medical conditions. In fact, it's the leading cause of disease burden in North America currently, and the second leading cause of disease burden worldwide. And the economic burden is staggering. $200 billion a year lost in productivity due to depression, and all of us have heard of or are affected personally by people experiencing depression. The person featured in this slide is Elena Kim, Dr. Elena Kim, who's a psychiatrist who currently works at the Center for Addiction and Mental Health. Elena was one of my trainees years ago, and she and I worked on this paper looking at how effective were antidepressants in people who had comorbid physical and psychiatric disorders. The most important part of that for this audience is people who have physical disorders. Because what what we discovered is that in persons who had significant medical comorbidities, antidepressants just didn't work all that effectively to treat depression. So the sobering statistic as a result of all this is that while medications are certainly used and can be very effective, their efficacy can be diminished in the context of a severe medical condition. Not to say that we shouldn't consider them, but just to say that we need to consider not just alternatives to medication, but combining medications to make them more effective. Resistant depression, and that is what we call depression that does not respond to conventional antidepressant medications, can affect upwards of 30 to 40% of people, and it's closer to 40% when we're talking about people who have medical comorbidities. And when we're talking about treatment-resistant depression patients, they're twice as likely to be hospitalized. They're 3 times as likely to receive more psychiatric medications for the reasons that I just mentioned. And it's not 6, but it's 19 times the total medical costs. I should update the slide. This is a recent statistic that the costs associated are much higher when one has a treatment-resistant depression compared to the medical costs of someone who responds to medications. I see a flip in the chat. Oh, never mind.
Yeah.
Is there something else
question.
that's there? Okay.
There's a question.
I'm going to try it.
You can see
Oh, here it is. Had a type of dissection, I had a type A and dissection and B repair when my anxiety is up, my heart rate shoots into the 90s at sit rate when it is normally around 70s. Is that a safe range? I guess the answer to that question is it all depends on what your cardiologist thinks. 90s tends to be a little high, but understandable in the context of anxiety. It's not life-threatening. If it gets higher than that, I would seek medical help. But if it hovers at around in the 90s, even high 90s, low 100s, it's a sign that your anxiety obviously is being triggered. And then there are ways of managing that anxiety that is important to consider. And I think we don't often consider simple things like our heart rate as a marker of anxiety. In other words, if your heart rate is up, you're more anxious. If your heart rate is lower, you're less anxious. But they can be good markers of anxiety. And I think it's important. The fact that you're even aware that your anxiety is up and that triggers your heart rate in 90s, I think is important, because either A, we can turn to treatments to help with anxiety, or B, treatments don't always, whenever I say treatment as a psychiatrist, people think of medications, and that's simply not the case. There are ways of managing anxiety without having to turn to medications. Deep breathing, relaxation training, mindfulness meditation, going for a walk, all of those are relatively safe and can help to lessen the anxiety. And it's not just a distraction. There are actually physiological mechanisms that take place that help us manage the anxiety and help bring our heart rates lower. And I can imagine that if you're a patient who's experiencing or who has experienced a dissection with repair, having your heart rate uncomfortably high can really feel dangerous. And to some extent, it can actually worsen the condition, because you have a significant cardiovascular event with a repair. Having your heart rate sit higher is a bit frightening. And if it stays high for too long, then I would ask that you seek medical intervention. But if it starts to come down, I think that's a good sign, and it's a sign that you're getting better control over your anxiety. Go ahead.
Another question that relates here to what we're talking about. What are your thoughts on, and do you recommend EMDR?
Good question. EMDR has been used to effectively treat mostly post-traumatic symptoms. And I'm by no means an EMDR expert. And I think the verdict on EMDR as a bona fide treatment.
Could you explain it as well, if that's okay, please, briefly, for
Can
those
I
who
explain
maybe are.
EMDR?
Yeah, just briefly for those who may not be aware.
Sure. EMDR is almost like a meditative type of practice where you think about the traumatic event and your eyes shift left to right. I don't want to communicate myself as being or portray myself as being an expert in EMDR, but there is an intentional behavioral step that one takes where they shift their eyes back and forth in the context of reliving the experience that is meant to drop the burden of the experience in people. And I don't know what the overall efficacy. I know that the efficacy has been called into question. Be that as it may, if people find the treatment helpful, then I would encourage them to continue it. I wouldn't want to prevent someone who has benefited from this treatment to prevent themselves from continuing to benefit from the treatment just because of my opinion. It's all about whether or not you feel the treatment has helped you. And if it has, I would encourage you to continue it. If it hasn't, or if you've not pursued that treatment, I wouldn't necessarily consider it as a first option. It's relatively benign in terms of its side effect profile, but it may not necessarily translate into a meaningful treatment response.
Thank you.
Okay. And the last point that I wanted to highlight is for remitters. That is, that people who are treated effectively for their depression, just because you've been treated effectively, and I hope I'm not painting too grim a picture, but just because you've been treated effectively doesn't necessarily imply that you're going to stay well. In fact, up to 40% of people can relapse at 2 years. So it's important to be really cognizant of your depression, particularly if you relapse, and even if you catch it, if you relapse and you catch it early, that's an important step to take to get the additional treatment that you need, because the more complicated, the longer the depression, the more complicated it becomes, the more resistant it becomes, and the harder it is to treat. So just want to emphasize that if you are experiencing depression, early intervention is important, and early prevention is important as well. Suicide is an unfortunate, albeit rare, outcome of depression, but it is something that we need to be mindful of. Mental illness itself can cut a significant number of years off a person's life expectancy. In Canada, 4,000 Canadians. In the US, over 40,000 Americans die by suicide every year. It's again a grim statistic, but it's something that has affected our communities not only now, but has for centuries. More than half of suicides involve people over the age of 45, and the statistics keep growing and growing. And not only do they grow in folks over the age of 40, but after accidents, suicide is a leading cause of death for people in Canada aged 15 to 34. And as you can see, this is a slide I assembled because it was largely targeted towards a Canadian audience, but the statistics are ubiquitous, meaning that suicide is a significant tragic outcome, leading to death, and second only to accidents in folks between the ages of 15 to 34. Here are US suicide rates. As you can see, they're growing. The only population where suicide has dipped a little bit is folks over the age of 75. But between 1999 and 2014, over the course of 15 years, the statistics keep growing and growing and growing. And we were hopeful when we saw some statistics in 2018 and 2019 that rates were going down, suicide rates were going down, but I think COVID only served to amplify risk for suicide, particularly as it pertains to loneliness. And what we saw was this reversal of folks over the age of 65 because of the epidemic of loneliness that folks over the age of 65 are experiencing. So, wow, I didn't realize time has flown by. Coping with a genetic aortic disorder, one needs to understand the diagnosis, and I'm not just talking about the physical diagnosis. I'm talking about all the features of their cardiovascular diagnosis, and one of those is to making sure that you're paying attention to behavioral health needs, and managing personally with ways to cope with anxiety and promote a sense of control. Having a genetic aortic disorder in and of itself can lead to feelings of fear and helplessness. I'm sure a lot of you, if not all of you, have experienced that at some point in time. I think it's important to not lose control, despite the medical conditions that you're experiencing, and feel like all help is and hope is not lost, especially in this day and age, where treatments are ubiquitous, widely available, and extremely effective. Stress management techniques. Chronic health conditions can amplify stress, and we need to implement stress-reducing strategies such as mindfulness meditation, yoga, relaxation exercises, which can significantly help folks manage anxiety. We need to encourage patients to explore different techniques until they find out what works best for them. Deep breathing may work for some people. Mindfulness meditation can work for some people, but not for everyone. And mindfulness meditation, I can tell you, is a very effective strategy, but some people just take to it more than others do, similar to yoga and similar to relaxation, which is probably the easiest form that most people can adhere to, at least for some duration. Be that as it may, it is important to consider all of these techniques. Stress reduction, stress management techniques do help, and we take them for granted and feel like they're an afterthought. We really need other forms of treatment, but I can tell you that in the context of people who do not necessarily have cardiovascular disease, but who do have anxiety and depression, exercise, as a simple example, can be an extraordinarily effective treatment, and often in mild to moderate depression can rival that of medications. And I encourage my patients to exercise routinely. I know exercise is a risk factor for patients who've had dissections and aortic repairs, and so it's important to follow your cardiologist and cardiovascular surgeon's recommendations around how much exercise you can take on. Be that as it may, things like mindfulness meditation are relatively low burden, if not relaxation inducing, and are often encouraged in patients with genetic aortic disorders. Building resilience through support systems, including social supports. Loneliness, as I mentioned, is a pandemic that our world is facing and has been amplified by COVID. We need to connect. We need to connect with social groups, peer groups, and share our experiences. And if you have personally benefited from those experiences, I'm sure you realize the importance and recognize how important it is to engage with others facing similar challenges and being able to help them. It is extremely comforting to have someone who can help guide you through their experience, and lend some advice, support you, but also be involved with friends and family. We often take for granted the importance of our social networks and our overall feeling of well-being, especially in this day and age where our electronics take up some of the most amount of time. I'm in front of a computer, but it's easy to lose ourselves in our electronics. But they are very isolating experience, and we need to remove ourselves from those feelings of isolation and socialize as much as possible, because it can have a positive effects on our wellness and well-being. Addressing health anxiety and medical adherence. Many patients experience heightened anxiety due to the fear of sudden complications, the fear that anything can go wrong at any moment. If you've had a dissection, you know what it's like to have post-traumatic stress disorder, because that experience usually happens quite suddenly and can feel like it's life-threatening. In many cases, can be life-threatening. Cognitive behavioral therapy is an effective tool to manage those conditions. Mindfulness meditation is also an effective tool to manage those conditions. But sometimes you need to resort to medications, and medications can have a significant role to play. But lifestyle changes may also affect adherence. And establishing structured routines, going to bed at the same time, waking up at the same time, can help organize your day and help reduce your mental health burden. It feels like a routine is often taken for granted. I can tell you that level of routine for everybody, especially those who experience a genetic or aortic disorder, establishing and organizing a routine schedule, an anticipated routine schedule, can help reduce the amount of arbitrariness in our lives and help us manage and cope with stress effectively. Making sure you reach out to healthcare professional. I do want to leave time for questions a little bit, so I will skip through this, but we've covered this topic. And promoting a sense of purpose and agency over control over your environment. Acknowledging and celebrating small victories can help maintain motivation, especially when physical limitations may alter life plans or goals. So do take the time to recognize and reward yourself for the small wins in life, because those are the ones that feel the most important. So Marfan's associated with considerable morbidity and comorbidity, including anxiety. Psychotherapy is important. Medications have a significant role to play. Lifestyle has a significant role to play. I have their CL psychiatry. If you're in hospital and you need to see someone for your anxiety or your depression, there are these folks called CL psychiatrists or psychiatry consult liaison team that oftentimes even if it's not a CL trained professional, it's a psychiatrist who has considerable experience in treating medical conditions treating psychiatric conditions in the context of the medical setting, and they can help you manage some of the anxiety and depression that you're experiencing. Be proactive about psychotherapies. They're often very effective in coping strategies, need to be holistic, including physical and psychological resilience to promote a sense of well-being. I'm glad I had the opportunity to speak to you all. This is an important and cherished responsibility that I often contribute to. I know how difficult it is to lead your life with these conditions. Again, there was a time where they were taken for granted, and I don't think we should be taking them for granted, obviously, because they do not only improve patients' quality of life, but they improve their medical quality of life and their medical outcomes as well. Thank you for the opportunity.
Thank you very much, Dr. Daskalakis. We have a question that just popped up right now. If you'd like to read it, if you can see it.
Sure. I have health anxiety and severe panic attacks. New diagnosis of aortic aneurysm. How do I control these panic attacks? It's a great question. Panic attacks are a sudden, unexplained nervousness and anxiety that can feel like you're going to die. I think the first step is making sure that they are in fact panic attacks and not related to your to a cardiovascular condition. Sometimes it's easy to, even though it's troubling to experience the panic attack, it's easy to immediately discount it as being related to anxiety and not related to a cardiovascular condition. So make sure that you report them to your cardiologist or cardiac surgeon or your primary care doc to rule out anything else. As I mentioned before, an arrhythmia can often be undetected, but presents as anxiety just because of the way the circuitry works in our body. If it is in fact panic attacks, the good news is that panic attacks are well controlled, especially if you catch them early with some forms of psychotherapy, but they're also well managed with medications. There are lots of medications, especially at this day and age, many different types of medications. We used to historically use tricyclic antidepressants, benzodiazepines, SSRIs and SNRIs to control panic attacks. Those are still very common. Here it says, I take Ativan. That's understandable. A lot of people who have anxiety can use Ativan. Is it safe to take Ativan? It is safe in the short term, but there are better options over the long term. And the reason that there are better options is because Ativan can be addictive and can actually lead to cardiovascular, long-term use has been associated with memory decline, and even short-term use has been associated with memory decline. So there are great alternatives to Ativan, including things like gabapentin, Seroquel, pregabalin that can also be used to effectively treat anxiety, as can SSRIs and SNRIs and even TCAs. So those are all reasonable options. But again, you need to turn to a licensed healthcare professional. Are there any known concerns about GLP-1 agonists with aortic dissection and post-surgical repair? This is outside of my scope of expertise. I don't know the answer to that. I know that certain GLP-1 agonists may be associated with some GI issues, but I'm not sure about their effects on aortic dissection or post-surgical repair. Post-surgical repair, if you're on, by the way, a GLP-1 agonist, please check with your surgeon, because if you're due for surgery, most anesthesiologists will now insist that the GLP-1 agonist is discontinued for a short period of time, because there's a risk of aspiration, getting liquid into your lungs because of liquid that remains in your stomach because of poor emptying of the stomach associated with GLP-1 agonists. So just be mindful of that you need to check with your doctor, especially if you're anticipating having surgery, because they typically recommend that those medications are discontinued. I've run out of time. I hope everyone found this beneficial. Good luck to all of you, and Linda will, if there are future questions, please do reach out and let me know. I can try to address them.
Okay, thank you so much. Thank you very
Bye,
much for your
everyone.
time this evening. Really appreciate your contribution. And again, if anybody has any further questions, they're welcome to submit them to GADA. We'll see what we can do to find the answers for you. Thank you again, Dr. Daskalakis, for your time and for answering some of them very specific personal questions. We appreciate it very much.
You're welcome. Glad to be able to do it. Bye, everyone.